a few minutes after 3 o'clock. Why don't we go ahead and get started? If you are here, you're joining a joint meeting of subcommittees of the MaineCare Advisory Committee. My name is Laura Cordes. I chair the Rate Systems Subcommittee. We also have folks with the Provider Subcommittee, and then we just open this meeting up to MAC members and interested parties. So I invite folks to put your name and organization into the chat if you haven't done so yet. This meeting is being recorded. We decided not to go webinar style, so folks could have access to the chat transcript, but we will share the recording back out with the MAC, and if the department would like to post it, they certainly can. From the MAC Rate System Subcommittee, we had a conversation about wanting just to know more about the progress that the state is making and the plans for value-based payments and alternative payment models. The state started in on doing some of that work several years ago and has already made some progress there that I think the Provider Subcommittee, and again, the Rate Subcommittee had a discussion with the department, I don't know, maybe a year ago, and folks wanted maybe an update. I think there was more of a focus on behavioral health system models. And so we wanted just to open it up a big picture and look at where the department was and have some time for Q&A. And of course, if we need more time, we could schedule another time at another date, but we're really happy to have Olivia Alford with us this afternoon from OMS to give us I imagine you might have a little bit of a presentation, but we'll also have some time for Q&A. So Olivia, welcome. Thanks for being with us this afternoon.
Yeah, thanks so much. I do have a presentation, but I also kind of had fun with it a little bit in that I was hoping that we could also just talk a little bit. And I wanted to avoid getting in too much detail about any one thing because I didn't really know who was going to be on the call. So I think I'm trying to paint a kind of a picture and give some updates of where we are, and then hear from everyone about thoughts and ideas and concerns and all of those things. So I'm Olivia Alford. I'm the Director of Delivery System Reform in MaineCare. I've been with MaineCare for almost 10 years, and I come from a health policy background, educationally, and also from working in evaluation, and way back when with supporting providers through technical assistance back in my earlier days. I live in Portland, and I'm originally from the Bangor area. That gives you a little bit of information about me. So we can go to the next slide. So I think, like I said, and Heather's here from my team, and she's helping do the slides, and also she's just a great person to also reach out to in the future if you have want to talk some more. She's great. One thing I want to talk about is, as I just introduced myself, I said my name is, I said my title as the Director of Delivery System Reform. If you've been around for a while, you know that MaineCare used to really talk about value-based purchasing, and we still do. But they're slightly different things, and we've actually kind of purposely shifted towards this idea of delivery system reform. So I want to talk about why that's important for this conversation. And then as far as the agenda, we'll go through some MaineCare examples of what we're talking about here. But again, I didn't know which models people might be interested in, so we won't go into too much detail about any one thing unless you want to. And our progress, as Laura mentioned, on this, some of the more concrete goals we've set for ourselves. And then we'll talk about challenges and opportunities. All right. So yeah, not to get into jargon, but it does sort of matter when we are talking about value-based purchasing, alternative payment models, and delivery system reform. What are we really talking about? So value-based purchasing is sort of a way of paying for services that incorporates performance, usually quality measures, into the amount that a provider takes home for payment. What's different between value-based purchasing and alternative payment models is when you start talking about alternative payment models, we're talking about something about a little bit more advanced from that even. We're talking about adding value-based purchasing to a reimbursement model that isn't just fee for service. So it's not your standard billing with pay for performance on top of it. It's a bundled rate with pay for performance or a value connection. It's a per member per month payment with a value connection. It's an accountable care organization. It's an episode of care. There's all sorts of terminology that we can talk about, but it's a little bit more advanced than just value-based purchasing alone. But again, what MaineCare has really oriented my team to, which is about 20 people that you may interact with in various capacities at MaineCare, is delivery system reform. And delivery system reform, this is my own definition just from this for this slide, is an effort to align care delivery, payment, policies, incentives, people, systems. I think I should have added in there attitudes, all sorts of things, technology. We could go on and on. It's the whole shebang of saying these payment policies are not the whole picture. It's about all the supports and all the things we're trying to do collectively to make health outcomes better and to control costs and to improve. I always like to ensure we're talking about improve the provider experience as well, is really one of the goals. And people can interrupt me throughout this. I'm a casual person, and so I'm happy to have you interrupt at any point. Some of the questions I've been getting recently and throughout is, well, does value-based purchasing work? And as with many things, it's definitely a mixed bag. When my team or I look at an issue, you'll look at the research for that particular issue. So recently, I see someone's here from the healthcare. I forget the name of the full name. Maine Healthcare Association. Recently I'm looking at nursing facilities a lot. So I'll look at the literature around nursing facility performance-based payments or value-based payments. You'll look at accountable care organizations separately. The evidence is mixed almost across all areas on whether value-based purchasing drives outcome, because every model is different. Every model has different parameters, different structure, different levels of risk or reward, different measures they're tying to assess value. They all exist in different, oftentimes state or sub-state or national contexts. And it's also true a lot of times that the period of evaluation for these programs is short, and some of the impacts you would expect to see are further out in time. That's one of the critiques of how the federal government operates some of their models. When they look at impacting the healthcare system, they kind of restrict these models to 5 years, and that's just not long enough to see the impacts. So absolutely, evidence is mixed. It depends what you're looking at. It depends if you're looking at a concrete cost. Are you looking at a cost outcome? Are you looking at a subset of a cost outcome? Like, are you looking for reduced admissions or readmissions? Are you looking to see whether all participants were successful, or were there only a subset of participants that were successful because of certain characteristics? So I could go on, but basically it's mixed, and I want to acknowledge that. Next slide. If you did want to get more into the weeds on this, I just included some links to some of the primary papers or places to start. The Healthcare Payment Learning and Action Network is the national organization that structures conversations and frameworks around alternative payment models, but they have a whole bunch of literature on their website if you wanted to learn more about social risk adjustment or primary care reform and maternity reform, all sorts of things. It's a wonderful website. And then the Centers for Medicare and Medicaid Innovation, the Innovation Center from CMS, has a guiding framework that I've linked to here that also is a way to think about this work. Next slide. What are the key principles to delivery system reform? So that bigger picture effort that we're all in to make things better. What is that about? we try to engage, I should say, partners early and often. Part of it is just being present and hearing from people continuously, not just when a new opportunity comes up, but listening and connecting the dots, looking for opportunities with you all at any point in time. So any point in time you have an idea, it's a good idea to reach out, or you have a concern and you want to think about it, good time to reach out. We're constantly looking at the national, what's going on nationally in other states, Medicare, other payers, and also just sometimes it's not even a payer item, it's a public health item, for example. We always are looking at supporting providers through transitions to different payment models with time, with tools like health IT or infrastructure or data sharing supports. We spend a lot of time trying to work across DHHS so that if Maine CDC has a priority, let's say lead testing, that we are reiterating or reinforcing the priority of blood lead testing in our programs so that you are hearing similar messages of priority from at least the state. And we try to bring in other payers, commercial payers. Sometimes, come to the table, sometimes they don't, but we try to always have that as a goal. We have some of our models are aligned with Medicare that you may, but more on the hospital primary care side. And then it's really important to design models to specifically address health disparities in underserved populations. That's a lot of the models might specifically be targeted at that, or it needs to account for that goal, whether it's a direct focus of the model or not. And then we've been planning and implementing these changes incrementally. As Laura mentioned, this is going on for many years, and people, always ask like, well, what's next? Don't always know, but we are trying to keep moving in this direction, and definitely more and more providers and members are being touched by this work. All right, I'll just keep going. So we have plenty of time to discuss. So you may have heard in the past, MaineCare say, we have a goal to reach 40% of payments tied to alternative payment models by 2022, the end of 2022. We did that. We actually did it. We didn't do a big announcement to congratulate all of us on that. It was during the pandemic, so it kind of just came and went. But we did reach that. We're actually at over 50% of MaineCare payments tied to category 2C, which is pay for performance or higher in the alternative payment model framework. That's a big increase over the last 4 years. And that itself is not really the goal. The goal is not just to change payment, it's again to see outcomes and to continue this work. So one of the things I'll put out there for everyone is that we don't have a new goal yet. That's part of what I need to think about is what's the new goal. And it doesn't have to be numeric. It could be outcome-based, it could be participatory, it could be other things. So I'll throw that out as an idea for you all to think about. And if you want to talk some more about that, that's on my to-do list. So, all right, next slide. I'm going to quickly go through some examples. Again, I see who's on the call, but I don't really know what you're necessarily interested in. So I'm going to go quickly through these, and you can raise your hand or put something in the chat if you want me to talk more about any of these. My purpose of showing you these are examples of value-based purchasing methodologies. So sometimes I think certain providers think, MaineCare does value-based purchasing is just a withhold arrangement with a bonus payment, or it's just the accountable care organization. It's actually a whole bunch of different things that are adding up to that 50%. And we don't do a great job communicating all these things in one place. So this is one of the first times I've tried to kind of do that. So if you want to go through them, Certified Community Behavioral Health Clinics may be familiar to folks on this call. Super excited about this initiative. Their performance-based payment structure is federally defined, or it has federal parameters that are defined, which led the state to develop our draft proposal for that to be basically a bonus payment structure of up to 1% of payments, with the contribution of different quality measures varying. So some quality measures are worth more than others. It all adds up to a potential for the CCBHCs in the future to have a 1% bonus payment. And that's, again, partially because the federal government defines how you can do this. And so led to this proposal. Next one, nursing facilities. This is going to change, I believe, but just as another example, the department's been working on nursing facility payment reform for some time. This model, which is complicated, I'm probably not going to go into the whole explanation, we proposed because we wanted to take into account that the way the nursing facilities were currently are being paid by MaineCare has certain incentive structures within it, even if it's not a value-based model. So we emphasize MaineCare utilization within the nursing facility rate structure. We wanted to continue to emphasize MaineCare member utilization in a proposed value-based structure. We also wanted to tie to quality outcomes. So what resulted is, and again, I'm not going to go into this because all of these are quite complicated on their own, is a proposal that tries to pull all those pieces together into a value-based model. It was a withhold with a bonus payment structure, and that conversation is evolving because there's been additional appropriations and things to support nursing facility reform. But that was what we went out there with a few months ago. Now, this model is something you all may, if you're more on the behavioral health or waiver HCBS home and community-based service side of the house may have seen, is more of a straight pay for performance model where there is a minimum threshold baseline expectation that needs to be met in order for the full rate to be received by a provider. So we withhold 4% of the payment, making sure folks meet the minimum requirements that are low as far as a quality measure score. And then if a provider achieves a higher level of quality, they receive a slight bonus payment. So it's an incentive structure with a withhold. This one, I think I want to note, is one where this rolls out. This gets back to my point about timing. When this sort of thing becomes part of a reimbursement model, it takes years to get to the point where payment's actually at risk, because you start off just having conversations about what is an appropriate quality measure for our program or our service. Then you start to measure that. You set the baseline. You give providers 6 months so they kind of are aware how their performance is, and then that 4%, as an example, becomes at risk for that minimum performance. So all of these kind of reiterate a principle here, is that they shouldn't be surprises to providers. They should be collaboratively designed, and they should be rolled out slowly. So that's something we can talk more about, but that's the intent behind some of these. And this one's super complicated, but I didn't know if we have any hospital folks on the phone. This is our hospital value-based supplemental payment program, which is a formulaic look at hospital service areas within the state of Maine and how MaineCare members are accessing primary care. So basically looking at geographic regions associated with the hospitals and saying how many MaineCare members within that geographic region access primary care. And the top 8 hospitals within those regions get a portion of the funding based on the size of that population. It's complicated, but we'll hear later why we chose that simple primary care measure to be part of a hospital's value proposition, because we all can think about hospitals and some of the incentives they have inherent in a hospital structure is you want to make sure that they're focused on primary care as well. All right. Any questions about those before I go into what I would call an example of delivery system reform?
Hey, Olivia, I have a question. Yep. Hi. So my question is specific to the 4% withhold and the 1% incentive. Mm-hmm. And so I was trying to follow what you were saying. So at one point, I know that we were looking at a system where the withhold occurs before the provider was assessed to see if they met the minimum requirements. And is that still how we're expecting the program to roll out?
Yeah, and you can go back to that slide if you want, Heather, if that's okay. So the program, are you talking about HCT, for example?
Yeah.
Okay.
Mhm.
So HCT providers are getting the full rate, right now you're getting your full rate. Even once a rule is, we propose a rule with you all with agreed upon performance measures, you're still going to get your full rate for a period of time until we publish a benchmark and then give you 6 months of data about your performance on that benchmark before we start withholding 4% of payments. So the withhold is prospective, but it is not immediate upon this becoming a part of the HCT reimbursement. I'm open to, I mean, we can have a conversation about that. I think the alternatives that we've used in the past were penalties for people who didn't meet the minimum. We'd have to recoup the portion of payment. That was not favorable. People did not like that one either. But that is how it generally would work.
Yeah, I mean, I understand it from that perspective. I think my concern, so, you know, I'm a provider. You know, we provide about 40% of the HCT in the state of Maine. And, you know, I can tell you that, like, I'm not concerned about meeting the requirements for this, you know, that will be in place, but I am a little concerned about 4% of my revenue being withheld before I am assessed to do that, because we, you know, our rate is the rate setting methodology didn't account for any kind of margin. It was a cost based 100% cost rate. And so when you receive 4% less than that, all the fixed costs that were part of that rate still exist: payroll, facilities, you know, utilities, all that stuff. So during that period of time, that, say, the 3 months that it's withheld and then the month or two that it takes for the assessment before we would receive payment, we're most likely going to have to incur interest costs to make those to pay for those fixed costs. And so what will happen is, even if we earn the 1%, the interest costs we will have incurred will probably be greater than that 1%. So there's almost no incentive in there. I mean, of course, we're going to meet the minimum requirements, and that's for an agency that meets the minimum requirements. You know, there's going to probably be a little bit of a net loss for us through that process if it's withheld before we're even assessed. Now, if we're assessed and then we're found to meet the requirement, and so we continue to make the full rate, then, you know, that's fine. There isn't obviously that unintended impact, but it will, you know, in a time where residential programs are closing and HCT is becoming more and more required and less accessible out in the community, it has the potential to slow down our ability to grow that service, and to get into those, you know, it takes investment to hire people in those sort of more rural areas, and it just limits our ability to do that if we're in a situation where revenue is being withheld. I mean, if we earn that through not meeting the minimum requirements, that's one thing. But if we're meeting those requirements, we're still going to have that impact. So I just hope people will consider that, think about that.
Yeah, so I think one of the things like that could be a reframing, but meaningfully, what you're saying is basically like, you could call it a penalty, or you could call it the penalty is a future withhold, basically, though it doesn't kick in until there is a performance issue, is what you're like,
Right.
reframing it to, yep.
That's what I would request.
Yeah.
You know, I'm not against there being an impact for not meeting the requirements. I just think, you know, we'd want to reserve that, I think, for agencies that aren't meeting the requirement. As it stands right now, it would actually be a penalty even for those of us that would be meeting the requirement.
Yeah, no, I hear you on that, and I will. I'll take that back. I think one of some of that becomes like an operational question about how to issue payments. But I
Mhm.
think and the recoupment, we want to providers do not like the recoupment process, but I think we're talking about something slightly different where it's like your rate gets reduced if you have a bad performance for a period of time, and then you could rebound and start having a full rate
Right.
again. So, yeah, it's a little bit different of a operational for us to operationalize, but
Mhm.
so I think that's good. And then I'll take that, definitely take that feedback and idea, and then I hear you say you have sort of a large you have a large panel for or at least proportionally to the state for HCT, and sometimes in providers that depending on the way that these are structured, that large panels make it easier for them to absorb these kind of things, and other times it doesn't. So I think I'm hearing you that on your side it would be problematic.
So we have a couple hands up, and
Yeah.
Scott, thanks for your question. I'm going to ask folks, because I'm not assuming Olivia knows everyone on the call and or can toggle between the chat, where again, if you've just joined in the last 10, 15 minutes, I invite you to put your name and org in the chat. But when you have your question, if you could introduce yourself, your agency, and if you're referencing a specific service, maybe spell it out, because other providers on the call may not know that particular acronym. Thanks so much. So we're going to go with Kat and then to Pete.
Hi there, Kat Brent. I'm a family physician, professor at University of New England, and an officer with the Maine Osteopathic Association. And I was actually part of the SIM grant years ago when we were working on the stuff that created some of this. So it's fun to see where it's coming out in the wash. Apropos of that, I'm wondering if in what you're doing, you're using clinical outcome measures as quality measures, and if so, who is choosing those?
Yeah, we thanks, and Dirk, I definitely recognize your name. We have a few clinical outcome measures. I guess I'll talk about, like, for example, we have HbA1c, poor control, and controlling high blood pressure in our some of those are in our ACO program, and some of them in our primary care model. I'm sure there's others that's coming to mind. Every time we select quality measures for a program, we do so with the providers and others partners as we go through that process. So CCBHC also has gone through a pretty extensive process. I believe they have some clinical quality outcomes in theirs. So it's a collaborative process. We look at a series of things, including impactability, accountability, where else that measure is being used. I'm thinking back to the SIM days, and I don't know if you're part of the work group that tried to align all the payers with 200 something measures.
I was, yes.
Yeah. So,
and concluded that it might be a lost cause because it changes so fast.
yeah.
So that was the next part of my question.
Yeah, I've seen those spreadsheets. I don't know if for the primary care work, it's an easy one to talk to. We are part of the Medicare's Primary Care First initiative, which had some goals and expectations around quality alignment, and we adhered to those. It was helpful for us to have that limited set of measures that we were required to at least partially align with. And there was only one other payer in the state who didn't have a very successful rollout of their primary care model to align with, and we tried to outreach to them. And I think the days of the SIM momentum and multi-payer aspects is not as strong today as it was back when SIM happened, State Innovation Model happened. We still try. Pete?
Hi, thank you. Yeah, my name is Pete Plummer. I'm the Chief Operating Officer of Woodford's Family Services. And it's kind of a follow-up to what Scott was saying in HCT, but it's really for all the programs that there's a 4% clawback or a 1% incentive, I guess, if you do well. It seems slanted, the 4% as being a number. If you don't hit you know, the benchmark, but only 1%, you know, if you exceeded it, you know, it's a big difference. And I just wondered if they could consider, you know, coming up with the same numbers, maybe a 3% clawback and a 2% incentive if you hit it, you know, just some other measurement tool. Just, it seems that that plan is punitive just by looking at the numbers, and it's not written to be helpful and supportive of agencies. That's really my only thought. But thank you for listening and taking the feedback.
Yeah, and I was talking to Michelle Herbert earlier about this, and I think, you know, at this point we want to acknowledge that some of this is about funding availability at times. And so once we you know, we have been recently putting forward that we think there needs to be a bonus side and upside to when we implement these things. We'd like there to also be an upside, and that's been marginal, as you've said, like 1% in some of these is lower than you might like to see. So I think it's a good conversation to keep in mind in the context of when we talk about advocacy for funding and where you want that money to go, like talking about like we want there to be a greater upside, because, you know, we can for some models that have achieved, some models that have a greater upside, or if they're bonus structure only, it's like part of it's the funding's been available.
Especially if you think the greater goal is to, if we enter these systems, it's supposed to save, you know, the healthcare system money in the long run, then by, you know, this approach, you know, seems to be kind of short-sighted, because I think more people would, if it was, would I don't know, it just seems to be off to me. But thank you, and I'm glad you're thinking about it and considering it. Appreciate it.
Thanks, Pete. And I'm going to check in. I see Mallory has a hand up. Olivia, let's take Mallory, and then I'm assuming you might have a few more slides. Is that correct? So we can go back to your presentation and then take more questions. Hi, Mallory.
Hi, Mallory Shaughnessy. Last 2 days of being the executive director at the Alliance. But Olivia, thanks for the presentation. And, you know, when we talk about the clinical markers and what we're looking at to decide whether or not people are hitting their quality metrics, it's just so important that they are tied more directly to the actual services that are being offered. And I know we've seen some things that do raise some concerns, like with HCT moving into this, where those are usually like 3-month interventions, maybe 4-month, but then tied to whether or not a child gets an annual exam, whereas they don't have any impact on that child's life beyond that intensity of service. But yet that's going to be a quality metric that they're held responsible for. So just trying to make sure that the metrics align well with this service and what they can actually impact. Does that make sense? And I hope you could hear me because I'm on the road.
Yeah. No, thanks, Mallory. And we are revisiting that. So we're not, I mean, I can't speak for Children's Behavioral Health Services, but we are meeting tomorrow about the HCT measures that were proposed and potentially rethinking the primary care one based on the feedback that we received the other couple weeks ago, or however long ago it was, from the HCT providers. So some of the questions are how this actually works out. The feedback was pretty strong on that one, really good points. We were trying to align across programs, but think that might have not been the best option. So we're going back. And if providers in that group have not yet suggested alternatives for another measure, like I would just encourage you to still reach out to me or anyone else that was on that call to give those alternative options.
And one other point real quick before I end, but to Pete's point about the 4% withhold and then the 1% bonus, is part of the equation really needs to be what services do we need to build out access for? And like HCT is one that, you know, 400, 500 kids on the waiting list forever. If it's something that we really want to incentivize building out, doing what Pete's saying in like maybe a 2% withhold and a 3% bonus, which would allow providers to actually hire ahead and build out the access. To think of when if we're thinking bigger than just, changing the payment model, but to do really service delivery change, I think we need to think incentivizing about the actual, where do we want to incentivize increased access? I would just add that.
Yeah, I think that's a great point. And I'll take that one as a, obviously timely conversation. And the other thing I'll add is that what we've all seen is that some of the times where these methodologies get added is when there's been a change in the payment, when there's been an underlying change in the payment. So when there's been a rate determination, and in these cases, like we switched from 15 minutes to weekly rate. So it was sort of tied to these other benefits that we thought we were providing to main care providers. Like they wanted, I think there was mixed reviews on that for HCT, but we heard that providers wanted a weekly rate. And we said, great, we'll do that. And we want to add performance-based accountability because there's increased risk with weekly rates. And so I think it's all trying to, again, like not just do one thing, but do it in the context of broader efforts. And of course, there's a whole lot of efforts on children's behavioral health right now as well. But I hear you on that, and I think that's a good timing for that comment. I'll go back to the slides just to illustrate. Heather and I had a good time this morning. Well, Heather did this, so Heather's slide. But what we're trying to illustrate here is when we're talking about delivery system reform, we're trying to create shared goals and incentives across all sectors when possible to get to an outcome. So with primary care, that's an easy one. It's very evidence-based that primary care reduces costs and improves quality, and that alternative payment models, not fee-for-service, is generally accepted as the best way to pay for primary care. So we're on all these different paths to increase the effectiveness of main care's primary care system. We have a payment model called Primary Care Plus, which is continuously being changed or advanced, I should say. We have our accountable communities who not only benefit from attribution through primary care practices to their ACO systems and financial rewards, but also we're requiring them to do population health planning and resource planning across systems. We have performance measures in the behavioral health home and opioid health home program forthcoming for behavioral health homes, but that incentivize primary care access for populations that may not have as much access or may not utilize primary care as often as other populations. You heard about the hospital incentives for primary care, and all of these things are, again, intended to say, like, let's make sure that when we're talking about primary care, everyone's sailing in the same direction, or I forget the phrase. The winds and the sails are all going in the same direction for primary care. So that's an area where over time we've been able to create that kind of momentum. I'm not going to talk about primary. I see Bobby from Maine Primary Care Association, but him and I can talk separately about Primary Care Plus if we want to. But next slide. Just to briefly say, main care is pretty aggressively and taking a while to get there, but trying to move forward with primary care payment reform to away from what you'll see in this slide. It starts off with per member per month payments on top of fee for service, and then moving into a direction where probably not all the way to the right, but where you're starting to partially replace fee for service with population-based payments. We are on that path in main care with our partners in primary care, and we're excited about that. That's an example, again, of more of a full-blown transformation of the care delivery system that we hope to come with that. And another complicated methodology I'm not going to go into. All right, well, that was just what we were trying to, we can take the slides down. We just wanted to give those examples, and happy to take more questions. I think what I was thinking, if people don't have other questions, is to just talk about, so you can ask questions, obviously, whatever you want, or we could talk about what other things about this work that you are excited about, and which are the things that, aside from what we already talked about, that you're not excited about, or you would see a challenge if you were looking to see more of this in the way that Maine Care operated.
Anybody have any-
I'll just say, I think that it has a lot of potential. You know, I'm all for creating sort of expectations for service lines and providers to make sure that the services that we're providing and that families are getting are what they need, and that they're not more than they need or less than they need. I think that's really, I'm sort of excited. I will say I'm excited about that. I've been very happy with the shift from the fee for service in our program to a weekly rate, because there's a lot in the fee for service that creates challenges in providing that service. It leads to a lot of turnover and things like that. And like for us, I don't know about other providers, but our turnover has dropped dramatically since I've been able to stabilize pay for my people and not having to fluctuate it because of the nature of the fee for service revenue. So that has improved the quality of the service because I'm holding on to people longer and they're getting better at their jobs. So I really appreciate that very much. I think it's a tough balance to say, how do you implement that kind of accountability and at the same time make sure that you don't decrease access or capacity in the system in a service that's, I think so critical right now with, sort of the situation we're faced in Maine with, the needs of families and sort of diminishing resources in terms of out of home placements and things like that. So I just feel like that's my concern. It's just, let's build it up and let's help it grow in let's help a quality service grow and develop, but let's be careful that we don't put something in place that's going to inadvertently go the other way and decrease that capacity to the what's available to families. I think that's my concern, or my worry about it, I guess. I guess I should just qualify. I'm a social worker, right? So I've done lots of different things that a social worker can do in the state of Maine. And by far, I feel like home-based intensive intervention, team-based, home-based intensive intervention, it was by far the most effective I ever was as a clinician. And so I have a strong bias towards it. I've seen what it can do. And I think that I would love to see it have another chance to shine like it did a decade ago in the state of Maine, when it was a really big part of our solutions back then, before it eroded.
Yeah, thank you for sharing that. And the team-based aspect that you raised is pretty common with all of these models, is that by moving away from fee for service, you're allowing there to be team-based care because no one's telling you can't get paid if only these certain people have this type of interaction with all these restrictions. So I'm a huge team-based care proponent, and also I love to see reduced administrative burden when it's appropriate, because that's just wasted time and resources. So I think those are some real benefits that we want to think about creatively too. Like, where else are there things that are happening or we're requiring that are causing that waste to exist, or restriction? I would love to have there be more flexibility.
Thanks. Kat, go ahead. Let's get you off mute.
It's only been like 5 years I've had to do that. Now I lost my train of thought. Couple thoughts. One, again, refreshing to see the primary care plus and where that's going. And as you're thinking about putting this into other arenas, an observation might be to perhaps model out or come up with some way to get off that left-hand column that you had in there, where you've got a lot of fee for service and a little bit of pay per performance. And in my experience of living through that several times as a primary care physician, that's where you lose people, right? Because you got a foot in both canoes and you're not getting rid of anything. And that's when burnout happens. you know, and I'm wondering if now we know enough from the experience of doing that, that we can sort of get out of that column beforehand, you know, like even model out what a care structure might look like. That's in that more mixed per member per month and fee for service. So
Yeah.
that's kind of a principle, that's something to do, and you're nodding like maybe you're already thinking that way, so rock
Yeah,
on.
I was like, maybe, yeah,
That's
you're gonna
good.
be excited. Heather and Bobby are gonna be your best friends.
Maybe, I love it.
Yeah, we're about to embark once we have our contract signed. You all know how that goes. With a
Yeah.
vendor who's moving us to what we call phase 2 of Primary Care Plus, which will be something
Yeah.
likely be partial capitation. It'll
Well,
be
and
something in
then-
that middle column.
Right, and what I was thinking though is extrapolating it into the other categories, right?
Oh,
So
yeah.
primary care is well underway, right? But you know, if you're going to the nursing homes.
Yeah.
If you're going into behavioral health, you know, to kind of take those lessons, extrapolate those lessons. And another place where that's going on, where this experiment is being done and is pretty mature, is in the direct primary care world.
Mhm.
And they've got a really good symposium, and then there you've, you know, got a different ratio, but you know, what works for being majority per member per month, but with some fee for service things for the things that are more containable.
Yeah, and
You know, chronic management cannot be done fee for service. Like we've tried for 30 years and it just doesn't work. You know, so.
and I'll put an ask out for, well, not an ask, if I can't ask you to do this, but the part of what you're saying about having a foot in both canoes, you know, part of that is because of other payers aren't participating. So to the extent that your revenue relies on other payers, like thinking about an advocacy point or negotiation point for you all to try to say, like, we want, when, you know, if you're in the moving towards these models, like you want to try to advocate for all of your money to be coming in the same way so that you can change the way that you're doing business. It may not apply to everyone on the call if you're heavily a main care revenue provider, but definitely important. And certified community behavioral health clinics is another area where that's a huge transformation for those providers. They're getting away from fee for service with a capitated model. So for those providers, it's also one of those big shifts away from the fee for service model. Exciting.
Anyone else? A question or comment? Olivia, I have a question, and I am not familiar, too familiar, I should say, outside of the space through main care, understanding these models. And my question to you is about the upcoming proposed lifespan waiver and services under the lifespan waiver that are being designed with an alternative payment model in mind.
Yeah, and I'm consulting with that team, but I'm definitely not the best person to speak to all the work that team's done. They're looking forward as well. They're looking to build in flexibility and they're looking to build in incentive. I guess I don't fully sure where they are in their process. So I don't want to
Fair enough.
speak to it, but I know that they're looking to do a little bit of that. One thing I'll say, and I was going to raise this as a national example, which I think, I'm not saying this is going to appear in the lifespan waiver, but I think there's a similar elements that might appear, is thinking about balancing perverse incentives. So like if you, for example, like there's national models where, let's just say, a lot of assistive technology is we want people to have assistive technology. We want people to use remote monitoring. All of those things improve outcomes and improve satisfaction or experience of care for the person. And they mean reduce revenue for the provider who set them up with those services, you know, so it's like there's this perverse incentive there. And I think it's important to balance those incentives out. So then like, well, let's reward, share in the savings or share in there's, you know, some kind of bonus payment or incentive structure so that we still have everyone doing the things that are best in the best interest of the client or patient or person. So I think those are common in the home-based space, those kinds of things. But yeah, the team is definitely looking for a few areas to increase flexibility and reward good performance in that lifespan waiver.
Thank you. Anyone else?
I have a question. This is Bobby Martin with the PCA. Hi, Olivia. So I'm curious as to if the state has designed a strategy. So moving off fee for service allows for greater flexibility of care model and care provision, and inevitably allows organizations and care providers to start moving more toward prevention. So using the same amount of resource and focusing on moving upstream consistently. When you do that and you look at the health care system as a whole, and you look at cost control, when you start moving money into prevention and away from acute services, you run into a dynamic where if there's no benefit for acute service providers to not be serving as many people in crisis or with complex untreated diseases, you get a kind of push and pull between the acknowledgement that the right thing to do and the cost-effective thing to do is to start moving resources upstream into prevention, early intervention, early identification. But then you're messing with people's slices of the proverbial pie. Is there a strategy that's being discussed at a state level to somehow connect both ends of the healthcare system, or even including the public health side, through to acute care, so that everyone's on the same page and so people aren't driven by that perverse incentive, which is also a very reasonable incentive. People have business models and staff, and they need consistency and need to be able to ensure that they can forecast what their revenues are going to look like. At the same time, knowing that the current state of the healthcare system in Maine and in the country at large is heavily reliant on people getting sick to drive interventions. And so is there a broader theory of change and really kind of holistic 30,000-foot view to start moving that? Because otherwise you spend more on one side and on the other side, and you're not containing costs. You may be improving health outcomes, but to do it all, to really move the system, requires some moving of some pretty big systems in a direction that can be uncomfortable.
Yeah, absolutely. So I think, well, I think what we have going for us is we have experience with accountable care organizations. We have experience with pretty good partnerships in the state, but there's a limitation to that with all that you're talking about. Even with the best intentions, there's limitations to how far that can go. I'll give an example. So I wouldn't say this, where the state is, generally speaking, I guess I'll say, is that there are global budget type models, like I think you are personally familiar with States Ahead, that was released from the federal government as an opportunity, as an example of how that type of cost containment and resources being less driven to certain types of providers could result in that distribution of funds being the way that you'd want to see it for the best outcomes. Maine looked at that model, and we just weren't there yet. There were too many pieces of how we would be able as a state to partner and execute a very complicated methodology to basically entirely change the way that we pay hospitals and that those resources are distributed among communities. It's a very big change that I think we were all interested in. We wanted Maine to be ready and to be able to explore that. We asked folks for their interest levels, and we got some interest, but it wasn't enough to take advantage of this model that the federal government was putting forward to Medicaid agencies and Medicare. So it wasn't right for a timing perspective. But I think what I would say for hopefulness is that, I think we're hoping that we can start to have some of those big picture conversations again in Maine. So, since the state innovation model, some of those tables where those conversations were happening don't exist as much anymore, but they do exist in pockets. And we have an Office of Affordable Healthcare at the state level now that's looking at some of these issues, and it's going to have to be relationship based for the whole state to come together and decide that we want to take on something like that. So we don't have an answer to that, but I think definitely trying to evaluate how we could get to a place where we had that kind of vision and path.
Thank you, Bobby. Thanks, Olivia. Pete? A quick
Sure, yeah, I have
question.
another question. Yeah, thank you. Thanks, Laura. Olivia, I have one more question for you. Are there other services that you and this, not you, but the state is considering, to go to the alternative payment method, in the behavioral health field or other fields? Are there other services that MaineCare provides? Just so we can kind of get ready or prepare or maybe help in some way.
Yeah, I'm trying to think. Our plates are quite full right now, and think if there's any that you wouldn't. I can't think of anything that hasn't already been mentioned. There are models that, like community care teams and palliative care, that Heather's working on. Heather here is working on community-based palliative care services. That will probably have a tie to payment or quality when they roll out, but they're not. So that would be, I guess, one that you may not know is in development. I can't think of anything we're not holding back anything that we were like, oh, we're going to go to this next. That's not really where we are. We have a lot of major initiatives in the works right now.
Yeah, because I just wonder, because I can see, the home-based stuff, the home health home and social workers do a lot, in that world, to Scott's point, and there's a lot of opportunity there in the homes, and there's different elements of in the home and in the social work, world, and those like adults, case management, Section 13, that's still fee for service.
Yep.
That's probably not, that would be a great change. We do that service and we do the monthly service also for our behavioral health homes, and we feel there's so much better outcomes in the BHH product and in the ACM 15-minute product. And ACM is confounded with Evergreen and all their problems too. So I mean, there's lots of reasons to move that along.
Yeah, and I'll just leave an open invitation. I know you have to close. Is that any ideas if you think your service, or if you have ideas, like I do appreciate reaching out to say like you proactively want to move to an alternative payment model. That's always good to know, and you don't have to wait for your rate determination to come up to offer those ideas.
That's good to hear, Olivia, and Pete, a good example of another collaborative model that's having some good success for kids. We are right at 4 o'clock. I want to thank Olivia and certainly Heather. It sounds like you all have new slides. Thanks for sharing that. And Olivia, at your leisure, if you can forward that, I'll send that out with the video back to folks, including the department. I also want to thank Shannon and Amanda for working to secure you. We know how busy you are, and thank all the members of the MAC and providers for joining this afternoon. We look forward to talking more about value-based purchasing, alternative payment models, and the delivery system. Thanks again, everyone, for joining. Have a good rest of your day. Take care.
Thank you.
Thank
Thank you. Bye, everybody.
Bye-bye.